Good evening, everyone. How are you? Hope you are doing good. I am Dr. Sultan Al Rashid, diabetologist. I have completed my fellowship in diabetology, accredited to Royal Liverpool Academy, United Kingdom. I am also a pharmacologist. I am currently working as an assistant professor in the Department of Pharmacology, Savita Medical College and Hospital. Today, I am going to discuss about one of the important topic: physician recommended anti-diabetic drug modification during Islamic fasting. Let's go into the topic. First one is metformin. We know metformin is used as the first line medication in the treatment of type 2 diabetes in overweight patients. The rate of severe hypoglycemia is minimal with the use of metformin during Ramadan. In addition, experts recommend that the 2/3 of the daily dose of metformin should be taken with iftar meals, that is the evening meal, while the remaining dose of metformin can be taken at the sahar meal, that is at the dawn meal. Next is DPP-4 inhibitors. The report suggests that the use of DPP-4 inhibitors in Islamic fasting is preferred over the use of sulfonylureas. The treatment with vildagliptin alone is effective in Ramadan fasting since it is associated with the lower incidence of hypoglycemia compared to sulfonylureas. Safety and effectiveness of vildagliptin make it a viable treatment option for the patients with type 2 diabetes who are willing to fast during Ramadan. So vildagliptin is very safe to use because of the lower risk of hypoglycemia comparing to sulfonylureas. Next is glucagon-like peptide agonist. We can use liraglutide because the effectiveness of liraglutide is comparable to the effectiveness of sulfonylureas, but the risk of hypoglycemia is lesser in liraglutide, so we can use liraglutide during fasting. Next is SGLT2 inhibitors. It is also safe to use SGLT2 inhibitors during Ramadan fasting, but the treatment with SGLT2 inhibitors should be initiated at least 2 to 4 weeks prior to Ramadan, as these agents are associated with diuresis and fluid loss because of osmotic diuresis because of the mechanism of action. Next is sulfonylureas. So considering that the sulfonylureas are insulin secretagogues, they are associated with the risk of hypoglycemia. So caution is advised in the patient using sulfonylureas during Ramadan. Use of glibenclamide is not recommended in Islamic fasting due to higher risk of hypoglycemia, while glycoside has been reported to be safer among various sulfonylureas in Islamic fasting, since the glycoside is associated with the fewer hypoglycemic events. If you want to use sulfonylureas, 2/3 of the daily dose of sulfonylureas may be recommended at iftar, that is during the evening meal, and with 1/3 administered at the sahar meal, that is during dawn meal. Next is meglitinids. Meglitinids are short-acting insulin secretagogues such as ripaglinide and nataglinide. Meglitinids are associated with the lower incidence of hypoglycemia compared to sulfonylureas. So the use of meglitinids may be preferred over sulfonylureas in Islamic fasting because of their shorter duration of action as well as the lower risk of hypoglycemia. Preferably, their daily dose is divided and they are taken before iftar as well as at sahar. Next is thiazolidinediones. Thiazolidinediones are the agonists of PPAR gamma receptors such as rosiglitazone and pioglitazone. The risk of hypoglycemia in thiazolidinedione monotherapy is very low and there is no need for dosage adjustment. However, the combination therapy may elevate the risk of hypoglycemia while fasting. And the daily dose is recommended to be adjusted as half a dose should be taken at sahar, while the remaining 1.5 dose should be taken at iftar. For example, if you are taking 45 mg of pioglitazone, 15 mg can be taken at sahar and 30 mg can be taken at iftar. So use of thiazolidinediones is not widely recommended during Ramadan because of their side effects like weight gain, water retention and risk of heart failure. So according to double-blind randomized multi-center study, the patient treated with pioglitazone during Ramadan had significant complaints of ankle edema and weight gain. So we should not use pioglitazone. It is not recommended during fasting. Next is alpha-glucosidase inhibitors. Alpha-glucosidase inhibitors include acarbose, xylitol and voglibose. So using these agents may have adverse gastrointestinal effects like flatulence, diarrhea, and abdominal pain. On the other hand, the risk of hypoglycemia has been reported to be low with acarbose monotherapy in a randomized double-blind study. So we can use alpha-glucosidase inhibitors, acarbose during the fasting. The successful use of alpha-glucosidase inhibitors has also been reported in diabetic patients in the Middle East during Ramadan. Next is very important thing, insulin. The blood glucose of the patients with type 2 diabetes receiving insulin therapy and those who are willing to fast during the Ramadan can be managed with the injections of intermediate or long-acting insulin as well as pre-meal rapid-acting insulin. The risk of hypoglycemia might decrease with the administration of rapid-acting insulin instead of using regular insulin. So we can use rapid-acting insulin instead of regular human insulin before meals. So in many Muslim countries, the management of patients with type 2 diabetes is performed using pre-mixed insulins. So in Islamic fasting, the patients receiving pre-mixed insulin, they are allowed to take half of their usual evening dose at the pre-dawn meal. So they should take half of their evening dose at the pre-dawn meal, that is at sahar, and they can take usual morning dose at the sunset meal, that is iftar. So fasting may increase the risk of hyperglycemia in the patients using insulin. We can reduce the risk by the use of basal insulin analogs like detamir and glargine, or by using rapid-acting insulin analogs like Lispro, Aspart, and Glulysin. Insulin pump is preferred in the patients with type 1 diabetes patients who are willing to fast during Ramadan. And monitoring of the blood glucose level is also advised in the patients receiving insulin in order to prevent hyperglycemia because of excessive eating during non-fasting hours and hypoglycemia caused by prolonged fasting. Additionally, by using the insulin pump, it helps to deliver the insulin continuously over the 24 hours, and it is easy to adjust the delivery of insulin from the insulin pump based on the blood glucose level. So you should use insulin pump in type 1 diabetes patients. My reference is Pakir Muhyiddin Altash, The Management of Diabetes Mellitus in Islamic Fasting, Journal of Nutrition, Fasting and Health. I sincerely thank Naina Muhammad Pakir Muhyiddin sir, who is the author of this article, for providing an innovative article at the correct time. Thank you so much, Ramadan Mubarak, and kindly share my lectures to your friends.